Yeah, dear Quang, thank you very much for the kind introduction. Dear Hans, thank you for the invitation here to Vietnam. It's my second time to visit Ho Chi Minh City. And also my thanks to Professor Tien. Dear colleagues, I'm going to talk about, as Quang already pointed out, a challenging topic, if the pointer works, the role of myocardial revascularization in preventing sudden cardiac death. So let's start with a patient example. This is a patient who presented to our hospital, St. Vincent's Hospital in Cologne in early May. He was 64 years old, presented with acute coronary syndrome, slightly elevated troponin, and suffered from dyspnea, New York Heart Association stage 3 to 4. Had in the echocardiography, as you can nicely see here in these images, a severely impaired ejection fraction, and as you will see in the next images during coronary angiography, had a significantly increased left ventricular end diastolic pressure of 26 millimeters mercury and was suffering from two-vessel disease, severe stenosis of the LAD, and as you can see in the next slides, also chronic total occlusion of the right coronary artery. On the right-hand side, you can appreciate the dilated left ventricle with severely impaired ejection fraction. So do we have already data to treat this patient by PCI or by CABG? Some weeks ago at AHA 2025, a meta-analysis has been presented which shows for the first time a mortality reduction with PCI in patients undergoing complete revascularization. So we as interventional cardiologists have to admit that so far there is no data except for the treatment of acute myocardial infarction patient to decrease mortality with PCI. This is the first study, the first meta-analysis showing that PCI of non-culprit lesions in acute myocardial infarction patients with multivessel disease reduced cardiovascular death and sudden cardiac death as well. So does revascularization reduce risk also in stable HF-ref patients so far? Do we have data for that? One trial we have to talk about is a STITCH trial published 10 years ago that compared CABG to optimal medical therapy. And in this trial, as we all know, it has been shown that CABG reduced mortality compared to optimal medical treatment only. So there was no PCI arm in this study. Another trial, which was discussed intensively, published 4 years ago at ESC, is the REVIVE BCIS-2 trial that showed that compared to CABG, PCI did not reduce mortality in a comparison with optimal medical therapy. So is PCI an option for our patient? If we look at our coronary, chronic coronary syndrome guidelines published by the European Society of Cardiology 2 years ago, we have a class 1B recommendation for CABG in patients with HF-ref and an ejection fraction below 35%, and only a 2B recommendation for PCI in our HF-ref patients with heart failure presenting with an ejection fraction of lower than 35%. So is PCI not appropriate to improve outcomes in our patients with ischemic cardiomyopathy? If we take a closer look at the REVIVE BCIS-2 study, and this is a study the guideline recommendation is based on, there are several issues in this study that we have to talk about. First of all, there's a severe and, in my opinion, critical selection bias due to the fact that 700 patients have been included at 40 sites in the UK over a time span of 7 years. That means only 0.2 patients per month have been enrolled. So actually you can think of including 2 patients per center per year. So I would say this is not the typical patient we see in clinical daily routine. Another thing I think is critical is that only stable patients have been included. Viability was tested, but not ischemia. So we know from CTO patients that if you treat patients without ischemia, that there will be no benefit. PCI was not performed according to the standard of care. We're taking more care of in these days, no consistent use of physiological measurements such as IFR, FFR, and also IVUS or OCT have not been used to optimize PCI results. And In my opinion, the most critical point is that the rate of unplanned revascularization in the control group, in the group that only received optimal medical treatment, was significantly higher than thought. Another thing is we have to talk about, and that has already been presented at the beginning of this session by Birgit Gericke, is that medical therapy improved a lot over time. So if you compare the arms of the STITCH trial with the REVIVE PCIS2 trial, only with regard to optimal medical therapy, you can see, even though that is not a randomized comparison, that the medical arm of the REVIVE PCIS2 study was significantly better than that of the STITCH trial. So at the end of the day, we don't have any data to answer this question I've been given for my talk with the existing data. But there will be upcoming evidence, the PROTECT-4 trial, CHIP BCIS3 and STITCH3 trial, all comparing PCI with CABG or optimal medical therapy in our heart failure patients with a low ejection fraction. So does this really help our patients we have been talking about, and can PCI at the end of the day reduce, maybe in certain situations, the risk of sudden cardiac death by increasing left ventricular ejection fraction? That has to be elucidated. I would say yes, and I'm going to show you how we did that and achieved that in a minute, because we know from this very old Valiant study that patients with a severely impaired ejection fraction have a higher risk of sudden cardiac death. So what did we do in our patient? On the left-hand side, you can see the echo that was performed during admission of the patient. Of course, because we are not only interventional cardiology department, but also have a very experience with rhythmology led by Quang Nguyen, we restored sinus rhythm, thereby increased ejection fraction already to 27%. Then, of course, this patient underwent, after he has been turned down by our cardiac surgeons in Cologne, myocardial revascularization. And this is a very good example as complex coronary artery disease. In this case, and this is very often the case, as we know, if it goes along with complex comorbidities and hemodynamic impairment, this is a so-called CHIP PCI patient. CHIP means complex high-risk indicated patient. And if three characteristics are coming together, we have to deal with the last patent vessel, RCA is occluded. And if we treat the left coronary artery, then this patient will be hemodynamically impaired. Of course, we will need an extensive lesion preparation. We know ejection fraction is still severely impaired. Left ventricular anti-systolic pressure was elevated. The only comorbidity in this case might be heart failure because the patient is still young. But in these patients, if we want to really stabilize and have a quiet procedure, then this is a very good reason for hemodynamic support with left ventricular unloading. One device for that was the intra-aortic balloon pump, but as many of you might know in Europe, this device has more or less completely taken off the market, and we tend to stabilize our patients during these high-risk procedures with an impeller pump here shown on the left-hand side. This is more or less a 12 French system, 14 French system, which is introduced via the left ventricular groin, and here by venting the left ventricle, giving you during the procedure heart volume output of 3.5 liters per minute. And what is important is these devices enable us to have a more complete revascularization during the procedure. So that's what we did in our patient. We started with a dual injection, as you can see here, to visualize the collaterals from through the septum from the LAD to the PDA. Then we had to dilate the LAD as we anticipated. It was already, even with the pump inside the patient, a significant hemodynamic impairment. Then we did what we tend to do in these retrograde CTO procedures. So we tend, if we think the antegrade PCI is not possible, we tend to go from the retrograde side. So we go through the septum with a non-torqueable microcatheter here, this Corsair Pro XS, and just take a Scion Black wire to get to the other side into the PDA, visualize that, then visualize also the distal cap, which seems not so ambiguous in this case, and which was not difficult to pass just with a cyan black wire. As you can see here in a live recording, that was quite easy. Nonetheless, the antegrade preparation of the RCA was not possible, so we also had to escalate in this case. And to make this long story short, finally with a guideline-assisted reverse cart, we were able to get with a retrograde Gaia-Next 3-wire into the antegrade catheter, as you can see here. And then the job is more or less already done. You externalize a long 300 centimeter RG3 wire. We did an IVUS just to appreciate which was the cause of the occlusion. It was a fibrotic plaque. Unfortunately, we had to stand over a very long distance, as you can see here on the left-hand side, with 3 drug-eluting stents finalized with a stent into the LAD and a kissing balloon inflation at the diagonal branch 1 bifurcation. And why am I telling this to you? This was a revascularization of the patient, and under optimal medical treatment with restoration of sinus rhythm and complete revascularization, he presented 6 months later to our hospital and had an improved ejection fraction, so-called HF-IMPEF patient, and he improved from 15 to 45%. We did 72 Holter ECG. There were no ventricular tachycardia or other ventricular disturbances, and think that his risk of sudden cardiac death now is reduced significantly so that he doesn't need an ICD. So, dear colleagues, let me please conclude my take-home message for you regarding PCI for the reduction of sudden cardiac death in HF patients is that, as I showed you with this meta-analysis, in acute myocardial infarction patients, we now know that complete revascularization of also non-culprit lesion reduces mortality and improves clinical outcomes. In specific individual patients, even though we have no evidence so far, no randomized study supporting this, with a multi-model strategy, taking into account optimal medical therapy, rhythm control, that's very important, and complete revascularization with PCI, we can have a meaningful improvement in left ventricular ejection fraction, and thereby I'm really sure we can reduce the risk of sudden cardiac death. What we also experience in this patient is that with unloading of the left ventricle and stabilization with the impeller pump, we were able to more completely revascularize this patient, even in this high-risk coronary anatomy. And finally, that's something we will have to see in the future. We will get some evidence for PCI in stable HF-Ref patients with major trials underway, PROTECT-4, STITCH-3, and CHIP-BCIS3. These are the names you should remember, and we'll see if this strategy also works in a randomized trial. Thank you very much, and come on.
Thank you very much, Malte, for the excellent talk. Are there any questions? Wolfgang? Yes. Yeah. Có ai muốn hỏi tiếng Việt thì câu hỏi cũng được nhé. Xin thầy Hùng. He is Professor Hung. He's a really expert of interventional cardiology and from the Cherry Hospital.
Yes. Quý đồng nghiệp, chúng ta có hỏi gì chúng ta cứ hỏi tiếng Việt cũng được nha. Còn không là nói luôn tiếng Anh. Dạ. First of all, we would like to congratulate with the case which is a very high risk patient. In Cherry Hospital, we also have many cases look like this. But about support for MCS in here until now, we don't have impeller here. So, for your opinion or your expert, you suggest for us about which device we choose to support for patient look like this. In Cherry Hospital, we use many IBBB to support for this case look like this. Open LOD first. After that, we go next to BCI CTO in RCA. And in other case, with the patient with hemodynamics, very collapse. So we have ESMO here. VA ESMO in my center, heart center, also have VA ESMO. But until now, we don't have impeller. How about your experience to this case? And in this case, I think Very good case. You show your technique also. Congratulations for your equipe. Okay, thank you. I have one question for you.
Yeah. Yeah, thank you very much for this great question. And this is a thing I would really love to answer with some evidence, but we don't have it so far. As you pointed out, I mean, it's not a bad thing to do these patients with an intra-aortic balloon pump. I have to say I'm really sad that the intra-aortic balloon pump doesn't play any role in the German market anymore, because Holger Thiele, we all know, I mean, he's one of the most experienced scientists in cardiology in Germany, but with his IABP Shock 2 trial, this device completely vanished from the German market. Not comparable to Vietnam, the US, and other markets. So I think that's not a good thing we did in Germany, but most of the centers, heart centers, and also centers like ours with no cardiac surgery on site don't have an intra-aortic balloon pump anymore. For economic reasons, it's also a disadvantage, I would say. I think, I mean, we did these procedures years ago without impeller and tend to do it in these days to stabilize the patient with left ventricular unloading. If you have to do a patient like this in Vietnam, I would be fine with an intra-aortic balloon pump and would be ready to escalate to VA ECMO. I mean, I saw the VA ECMO program here in one hospital in Ho Chi Minh City, and I was surprised and impressed how much experience you have with that device. So if you have to treat a patient like him here in Vietnam, I think it's not a bad thing to start with an intra-aortic balloon pump, but be prepared to escalate, maybe have a sheath in the groin or something like that, to escalate to VA ECMO in case hemodynamics deteriorate.
Thank you very much, Malte. We have to move on for time reasons. Thank you very much. And fortunately, Professor Krötz is coming right in time from the airport and have this talk about the edge-to-edge valvular repair. Which patients are suitable and which are not?
Okay, thank you, Quan. Thank you, dear organizers, dear professor from Vietnam. It's a very great pleasure for me to be here once again. It's